Should I start?
Yeah.
Thanks, Dr. Rohit sir. It's been a tremendous course so far, and let me see if I can keep the interest alive. So this is a heart brown cataract. Patient is quite senior, 75, 80 years old, and we've done a femto-assisted surgery here, and so small LRIs as well. Now, as we proceed with the surgery, looks like a routine cataract surgery. We've gone with the femto-assisted steps. I'll run through those, and after that making the side ports. These are calibrated side ports like Dr. Rohit likes to make as well for better chamber stability, get the that capsular tag out. Now when I try to rotate this lens, I realize that there is some zonular laxity, so I don't rotate it very vigorously. It's a hard brown cataract, and I decide that I have to very patiently get this out, and once the nucleus is out, I'm more comfortable. But see what happens the moment I get that out, that whole bag starts pushing forward, and I decide that I need to get the cortex out. So you do see that irritating bit of small secretion on the cornea, so just ignore that. This is going to obstruct the view a little bit here. It's on the tear film. You can see it cutting across the cornea. It's an artifact basically. Now I'm proceeding comfortably and getting everything out, but then I get the bag out. So you can see that I caught the bag, and it was already a bag which was very lax. So in that hurry to get that last bit of cortex out, I have now done a reflux and I've freed the bag, and now I have to inject viscoelastic. So I infuse, get that out, and at this point I make the big mistake. I shouldn't have come out all the way. I thought that this would not cause a problem, but I should have seen that first step where when I had brought the infusion out, the bag had started rising up. So what should we do at this step? I've already made a mistake. What should be the next step? Anybody wants to volunteer? That bag is dehisced, over here. So should I go back with the infusion or do something else? Put in viscoelastic. Sorry? Port visco? Okay. Kumar, you want to do something differently?
No, I think put in viscoelastic and then put a CTR.
Okay. So let's see, I'll try to put in viscoelastic. Now you can see some movement happening there already.
Wow.
It's not the vitreous, but see what has happened now. I tried to put in viscoelastic, it pushed the whole bag away.
It pushed the whole bag
I chose
off.
the wrong port to put the viscoelastic. I should have gone from the other side port, which was somewhere here. I went in from the wrong port. Now the bag has kind of, pushed away. I think now we can ask Dr. Amar what he wants to do at this point. So he would say, get the bag out and go ahead. So I'm going to see what we can do now. I go back to the other port. Now ideally my viscoelastic cannula should have been having a smaller gauge, because this gauge is, my side port is just 22.
That bag is quite fully gone.
Yeah, it's almost fully gone, but let's see. So I'm now going to go back and try to distend that bag and see. I'm checking for what's behind and see if there's still some scope, because I still have some cortex sitting there. Now I'm going into the bag and injecting viscoelastic, trying to inflate that bag. And now that I have the bag in place, now comes what David was trying to show you. I'm trying to put in a CTR, and I was seeing that video and I was saying that that was a lesson in what I decided that that's the wrong way. And David, as you said there, trying to go the other way now. And now again I find that it's pushing it away, trying several ways to bell the cat. And now I'm kind of pushing it in such a way that most of the CTR is in, but it's not helping. See, it's almost going to cause the whole thing to get broken. So there's no way it's going to go there. So what should we do now? David, you want to sort this out for me?
That bag is
I wish
officially
I
dead.
had that CTR injector you have, but I don't have it.
No. Well, I don't think the bag's worth any support at this point, and other than maybe holding back the hyaloid face, but it's going to contract and crumple up. So I think you're going to have to plan on how to put the lens in without capsule support. So glued IOL would be an option.
Good option.
And then maybe you'll be able to grab the bag and extract it without doing a vitrectomy with forceps.
So, but I don't want to give up. I want to see if I can still put in the CTR. So I'm trying another direction. So that doesn't work either because it's not entering the bag. The bag is now a little behind. So I'm going from the other side port now. And I'm now going to do a guided kind of a thing. And this time on the SCRS, I'm going to pick up that injector that you showed. So it seems to be behaving so far. And so I got lucky 4th time. And now I don't like to do what I'm doing right now. If I have to do this, I go in with a micro forceps and just go in and release it there because sometimes it will just get dislodged. I was actually very keen to bring this cortex out first and then decide whether I want to keep this back. So I'm putting in capsular hooks now. A little too late in the day, but putting in that lens and then nudging it there. So the good thing is that if you have a CTR in the bag, of course this bag is almost gone, and I probably should have sutured it to the thing, but of late in 5-10 years when this patient comes back with a little bit of tilt, I just pass a suture around the CTR and just anchor it to the sclera. I've done a few of those, and sometimes it just they don't come back anyway. So this was kind of at the end of the surgery, still looking good.
Would you have fixed it to the
I should have, but
because it was
that's exactly what I said. I should have probably put in a CTS and anchored it at least in that one area. But since on OCT the IOL was perfectly, there was no tilt and everything, and there was CTR inside. So in 6 months or a year, if this patient ever, has a thing, usually they don't, but if in a few years they start with a dead bag or whatever, if they start kind of, having a small tilt, I just put one suture around the CTR because it's fibrosed by that time. And wherever it is, I just anchor it to the sclera at that point. And there have been only very few that I have had to. But sometimes I go in with a CTS and do a bipolar 2-point fixation.
Just one thing I suggest is, even if you're fixing a lens, I think a 3-piece would have been better off, no?
So 3-piece, of course, if I was not having a CTR, then 3-piece for sure, because then 3-piece you can do a glued IOL if you have
That's
to.
what
right?
I'm saying.
But
suppose by chance it falls down, I'm saying 5 years later.
So you with the CTR in the bag, for the capsular bag complex, if there's a CTR, you can just pass the suture around the CTR and fix it. So. Yeah, but if the bag went down, then the whole thing would have gone down anyway, right? So. I
David?
agree, but the putting a 3-piece into the bag in such eyes sometimes does so much more manipulation that you end up having a bigger situation and more kind of manipulation on the bag. So it was just easy to do it, and then with the CTR in C2, I find that the CTR itself works like a anchoring point for you down the line. In a few months, it's already fibrosed and nicely kind of stuck all around, and you can easily, with the IOL inside, you can just fix it. I mean, that's my way of doing it, but I completely agree that 3-piece lenses would be great, especially because if you have to glue them later on or you have to do something else, it's very easy to kind of use them for doing it. So I think that way is
Till how many hours, David, do you lock it by capturing a 3-piece, the optic, and with the haptic in the circle?
Yeah, I think this is a tough case because the CTR makes it look so good at the end of the case, and I think we're all concerned about will it stay that way. But you have a good approach, which is with that CTR, and you can always go back unless it really drops down. But the advantage of a 3-piece in the sulcus is you're really having the haptics contacting the ciliary body in 2 locations. So you're getting a little bit of almost like a scleral support without a suture, and the bag is keeping things up. The CTR is going to keep your bag from crumbling, but we already saw we're missing maybe 7 clock hours, 8 of zonule. So it's a good case because I don't think we have a consensus.
And how about locking it with
Yeah, I mean, I think optic capture is very important here because the dialysis is so large. And if the lens is a really good point, a 3-piece in the sulcus, it just rotates till it finds that opening and then it goes through because whether rubbing or eye movement. So optic capture, because you did preserve the rhexis, is and also keeps the bag from contracting. A lot of benefits to that.
So David, you would have put the 3-piece in the sulcus and did a posterior capture.
And then
with the TCT.
optic capture. Yeah.
Perfect. So I'll just share this second case, and I think this was an intumescent cataract, and I like to decompress these lenses from a new port. I don't like to go from the main port because that allows the viscoelastic to escape. So here again I'm making a mistake. I'm not stabilizing the globe, so I'm just trying to get in, and it's not a very sharp needle for some reason. So there goes, and there goes. I've created a radial tear in the capsule. It's all the way till the. So that was a sudden entry for the 26 gauge. You can see that it's kind of gone right till there. So now I wanted to decompress this lens, and I've created a new small flap, and I'm going to decompress it anyway, even though I know that there is a weak area over here, whereas there is a radial tear in the capsule. And now I want to kind of go around it. So I wanted to ask, Tushya can tell me maybe. I've done this in your OT once, if you remember, in live surgery, with the side port knife, and gone and punctured the capsule, and I had 3 people standing all around me trying to guide me how to recover that. So how would you do this one?
So I would probably take the needle and decompress it first in the center, and then make a small rexus in that decompressed area.
So
Like
I
how-
already decompressed it here, but
Yeah.
this thing is gone from here till here.
Yeah.
It's like reaching.
So
about-
we can go around it and
Mhm.
merge that.
Right. So that's what I'm going to try. I'm just going to try and go around it. So oval rexus around that. See, I'm going from both sides now because I don't want to have a break. And then I'm just trying to go all around it. And see, I'm making a mistake. I'll probably need the Brian Little's maneuver over here, because it is still intumescent even after decompression in the periphery. So I'm going to go from the side port now and see if I can recover it. And yes, I can. So then I enlarge the rexus as well, because now I'm all around that area. And now I'll just get a rexus all around. So with this, I was able to save the day. And do we have time for one more, or I should stop? I think